Le voy a pedir a la doctora Alvis Hani. La doctora Hani, ella es una gastroenteróloga, neurogastroenteróloga colombiana. Ella es una experta en trastornos esofágicos y de la motilidad, y le hemos invitado para que coordine, si nos acompaña. Ella va a estar coordinando este primer módulo con el doctor Miguel Ángel Valdovinos, que está por integrarse con nosotros. Y la idea de este primer módulo es enfermedades esofágicas, ¿no? Trastornos motores del esófago, enfermedad por reflujo gastroesofágico. Y recordarles que a los pasillos hay micrófonos. Terminando cada módulo tenemos una sesión de preguntas y respuestas. Invitarlos a que se unan a esta sesión de preguntas y respuestas. Tenemos expertos de talla mundial y creo que será una muy buena sesión. Sin más preámbulo, igual cedo la palabra a la doctora Hani para que empecemos las actividades. Bienvenidos.
Buenos días, doctor Remes. Primero quiero agradecerle a usted y a su junta directiva esta invitación y el honor que me hace ayudándome aquí con la presentación sobre esófago, y quiero iniciar presentando al doctor Marcelo Vela Aquino. El doctor Marcelo Vela es muy conocido, es profesor de medicina, director de la sección de trastornos esofágicos y director de la residencia avanzada en enfermedades del esófago en Mayo Clinic, Arizona, Estados Unidos. El doctor Marcelo Vela nos va a hablar de cómo abordar la disfagia. Bienvenido, doctor Vela, y muchas gracias por estar acá.
Gracias, Alvis. Bueno, primero que nada agradecer a José María, a todo su equipo, a los organizadores del Congreso. Como siempre es no solo un honor, sino un motivo de gran placer estar acá en México entre colegas y amigos. ¿Podemos poner mis diapositivas? Bueno, tenemos 15 minutos para hablar de cómo abordar la disfagia. Esto obviamente es un problema sumamente común, un motivo de consulta muy frecuente en consultorios de gastroenterología. Y la idea va a ser hablar de una manera global, muy básica, en qué tenemos que pensar cuando un paciente acude por disfagia. Recordemos primero la fisiología normal, cómo funcionan las cosas cuando todo está bien. Existe obviamente una fase orofaringe de la deglución, la cual tiene componentes tanto voluntarios como involuntarios, llevados a cabo por músculo estriado de la boca, faringe y el esfínter esofágico superior, y cuando ya se transfirió el bolo hacia el esófago proximal, entonces viene ya la fase esofágica, la cual es involuntaria y llevada a cabo principalmente por el músculo liso del esófago, ¿no? Entonces, cuando todo anda bien, el paciente logra iniciar la deglución, componer el bolo, empujarlo con la lengua hacia la parte posterior de la faringe, cerrando la nasofaringe para evitar regurgitación nasofaringea, luego cerrando la vía aérea para protegerla y finalmente transferir el bolo hacia el esófago proximal con un buen aclaramiento. Cuando las cosas no andan bien, y les recuerdo, esto involucra acciones complicadas de 26 músculos y 5 nervios, algo que requiere una coordinación muy certera y muy rápida, pero cuando las cosas no andan bien, el paciente puede tener dificultades para formar el bolo en la boca, puede tener un pobre cierre llevando a regurgitación nasofaringea o a aspiración hacia la vía aérea y retención de material residual en la faringe. La deglución normal en el esófago, cuando todo anda bien y la mucosa no tiene ningún tipo de daño ni lesión obstructiva, eso se lleva a cabo obviamente por la onda peristáltica, que se puede medir con estos catéteres de alta resolución que nos proveen estas topografías de presión esofágica. Muy brevemente, pueden ver acá la apertura del esfínter superior, esto se pone azul, es decir, presiones bajas, y esto va seguido de la onda peristáltica, y pueden ver una buena relajación del esfínter inferior acá. Esto es cuando todo está bien. Ahora, la fase esofágica puede verse afectada porque hay algún problema obstructivo en la mucosa, una masa maligna, esofagitis eosinofílica, a lo mejor estenosis péptica, O en algunos casos todo anda bien, la mucosa está completamente sana, pero puede haber un problema en la peristalsis o una pobre relajación del esfínter esofágico inferior. Entonces, con todo eso en mente, ¿cómo abordamos al paciente? Obviamente es muy importante hacer una buena historia y hay acá unas preguntas que son muy importantes. Primero que nada, si se trata de verdadera disfagia o de globo, ¿no? Porque como tantas veces estoy seguro han visto pacientes que llegan referidos por disfagia y lo que tienen es globo, y ahí sí que el abordaje diagnóstico y terapéutico es distinto. Entonces, primero que nada, establecer esto. Y luego, asegurarse si se trata de un problema de dificultades para transferencia orofaringia o si el problema está más en el esófago. El paciente con dificultad orofaringia va a reportar dificultades para iniciar la deglución, regurgitación nasofaringia, tos, ahogamiento, usualmente inmediatamente a la hora de tragar. Incluso en el consultorio, si no están seguros, se le puede dar un vaso de agua al paciente para que trague, y a menudo pueden ver ahí los problemas de tos, ahogamiento, regurgitación, etcétera. Importante, obviamente, como lo saben todos, distinguir si es disfagia para sólidos, líquidos o ambos, si es intermitente o progresiva, y buscar también síntomas adicionales. Esto no es perfecto, pero nos pueden dar más o menos una pauta de a lo mejor dónde está la etiología, si hay pirosis, si hay dolor torácico, si hay pérdida de peso. E importantemente, si hay odinofagia, uno ya piensa en esofagitis infecciosa o a veces en esofagitis de contacto químico por píldora, ¿no? También tener en cuenta algunas comorbilidades que pueden tener relevancia, como enfermedad de tejido conectivo, que a veces resulta en disfunción peristáltica, inmunosupresión, y también historia de radiación, trauma o cirugía, y medicamentos que pueden causar esofagitis por píldora, como les había dicho. Y ojo con los opioides, porque eso es que está ya muy bien descrito. Los opioides pueden causar disfunción motora del esófago con presentaciones como acalasia o una obstrucción al tracto de salida de la unión esófago-gástrica. Entonces, primero que nada, distinguir si se trata de un problema de transferencia orofaringia o si se trata de disfunción esofágica. Si el paciente lo que reporta es dificultades de transferencia orofaringia, entonces hay que pensar en etiologías, por un lado, estructurales, entiéndase, bueno, obviamente un tumor o una hipertrofia cricofaringia, estenosis por radiación, etcétera, o en causas neuromiogénicas, el paciente que ha tenido un derrame o que tiene algún otro trastorno neurológico. Y acá en estos pacientes hay dos asuntos muy importantes. Primero que nada, si hay una lesión o un desorden corregible, es decir, una estenosis que a lo mejor puede dilatarse durante la endoscopía, o una condición sistémica que puede responder al tratamiento, como la miastenia, algunas miopatías, por ejemplo, que sí responden al tratamiento. Y el otro asunto muy importante en paciente con problema de transferencia orofaringia es el riesgo de aspiración, porque ahí sí que es nuestra responsabilidad evitar que el paciente aspire, y entonces, basándonos en el tipo de trastorno que el paciente tiene, a lo mejor el paciente no puede tener administración de alimentos por vía oral y va a necesitar una vía parenteral, ¿no? Eso es muy importante para proteger al paciente. Si el paciente no tiene problemas con la transferencia orofaringia, dice, no, yo puedo tragar bien, no me ahogo, pero siento que todo se me atora acá en el tórax, entonces empieza uno a pensar en qué puede explicar el problema desde el punto de vista del esófago, obstrucciones mecánicas o estructurales, como un anillo de Schatzky, obviamente un tumor, alguna estenosis causada por enfermedades inflamatorias, o una hernia paraesofágica, por ejemplo, puede resultar también en disfagia. Otros pacientes sin una estenosis crítica o a lo mejor muy obvia durante la endoscopía pueden tener problemas inflamatorios. En el medio donde yo trabajo es sumamente frecuente la esofagitis eosinofílica, obviamente reflujo. Cada vez estamos viendo más esofagitis por líquen plano. Otros pacientes pueden, sobre todo si acusan odinofagia, a lo mejor pueden tener candidiasis o una infección viral. Esto lo vemos en algunos pacientes inmunosupresos. Y de nuevo, si la mucosa está completamente bien, a lo mejor lo que se trata de lo que se trata es de un trastorno de la motilidad como la acalasia. Por último, existen algunos pacientes que no tienen ninguno de estos problemas, la mucosa está completamente bien, la motilidad está perfecta, y lo que tienen es un trastorno de disfagia funcional por hipersensibilidad y por hipervigilancia, y hay que tener esto en cuenta porque estos pacientes se pueden manejar con neuromoduladores, con intervenciones en la clínica de psicología gastrointestinal, es decir, se les puede ayudar también, ¿no? Bueno, hablamos ya de historia. El examen físico en realidad no contribuye tanto, a menos de que uno tenga evidencia de alguna enfermedad sistémica que puede relacionarse a la disfagia, y toca entonces enfocarse en los estudios diagnósticos. Si el paciente tiene dificultad orofaringia, hay que referirlo a un terapista del área de deglución para que le haga un trago de bario modificado, o esto se puede estudiar también a través de endoscopía transnasal fibroóptica con evaluación de la deglución. Si el paciente tiene disfagia esofágica, la conducta es ir directamente a hacer una endoscopía. Antes decíamos a lo mejor un trago de bario, pero la endoscopía permite examinar, biopsiar y en muchos casos tratar también de una vez haciendo una dilatación. Y las otras herramientas pues son estudios de motilidad esofágica. Tradicionalmente la manometría de alta resolución. Hoy día está disponible en algunos sitios hacer una manometría por flip, es decir, evaluar la motilidad durante la endoscopía. El paciente se le hace la endoscopía, todo está normal, antes de que se despierte se le introduce el catéter de flip y ahí se puede hacer una evaluación en la misma intervención endoscópica. Y por último, sigue siendo muy útil, muy importante, estudios radiográficos, entiéndase el trago de bario. Entonces, ya en cuanto al abordaje diagnóstico, de nuevo, lo más importante, determinar si existe problema de transferencia orofaringia o si se trata de disfagia esofágica. Si es un problema orofaringio, hay que referir al paciente para un trago de bario modificado o evaluación fibróptica de la deglución con un experto que se ocupe de eso. Si la disfagia es esofágica, de nuevo, vamos directo a endoscopía porque esto nos puede mostrar, bueno, en el peor de los casos, como en este ejemplo, una masa maligna que está aquí surgiendo en un tejido de epitelio de Barrett. A veces podemos encontrar candidiasis, un anillo de Shatsky, de nuevo ya con mucha frecuencia, y más adelante van a ver una charla acerca de esofagitis eosinofílica. Y como les indicaba, la endoscopía permite inspección, tomar biopsias, tomar muestras, y en muchos casos también ofrece una oportunidad terapéutica dilatando al paciente en la misma intervención diagnóstica, ¿no? Ahora, si la endoscopía es normal, entonces sí toca hacer una evaluación de la motilidad. Una opción es referir al paciente para que se haga una manometría lo más pronto posible, pero la otra opción es, como les indicaba, en esa primera endoscopía diagnóstica, si todo está normal, ahí mismo hacer una manometría de flip, y si el flip es normal, el paciente no va a tener ningún trastorno accionable en la manometría. Este paciente se trata ya como de disfagia funcional, pero no va a tener un problema de manometría, es un problema de motilidad. Si el flip es anormal, entonces ahí lo más probable es que sí requiere una manometría para clarificar exactamente qué es lo que hay y cómo tratarlo. Y de nuevo, bueno, el flip no está disponible en todos lados y seguimos siempre apoyándonos también en muchos de los pacientes con un trago de bario que continúa siendo útil e importante. Ya para terminar, les recuerdo, la disfagia es un problema sumamente común, un motivo de consulta a clínica de gastroenterología muy, muy frecuente, con un impacto significativo en la calidad de vida, en algunos pacientes también en la habilidad para nutrirse. Y cuando estamos evaluando al paciente, recordemos siempre que están estas dos fases, la orofaringia y la esofágica, porque la normalidad que el paciente reporte es lo que va a determinar cómo lo vamos a estudiar. Si el paciente reporta problemas de tránsito orofaringio, se ahoga, tose inmediatamente después de tragar, entonces hay que hacer un test de deglución por un terapista del área de deglución, buscar causas corregibles, ya sea estructurales, como una hipertrofia cricofaringia, algún tipo de estenosis, o causas sistémicas corregibles, como algunas de las miastenias que pueden tratarse a través de medicamentos. Y muy importante determinar el riesgo de aspiración para proteger al paciente que no resulte con neumonía. Si la disfagia es esofágica, el tránsito orofaringio está bien, entonces nuevamente les recuerdo empezar con endoscopía. Si esta es normal, tenemos algunas opciones para evaluar la motilidad y apoyarnos siempre también en estudios radiográficos, entiéndase el trago de bario, que continúa siendo muy útil y ampliamente disponible. Muchas gracias.
Bueno, muchas gracias, doctor Vela, por tan excelente y didáctica conferencia. Quiero comentarles que ya está el doctor Valdovinos aquí al lado mío. El doctor Valdovinos realmente no necesita presentación. Es un gran maestro de la neurogastroenterología y ha sido profesor de muchos de nosotros, no solamente en México, sino en muchas partes del mundo. Muchas gracias, doctor. Bueno, a continuación tengo el honor de presentar al doctor Prakash Yawali. El doctor Yawali es profesor de medicina y es el director de neurogastroenterología y motilidad de la División de Gastroenterología de la Universidad de Washington, Escuela de Medicina en San Luis, Missouri. Bienvenido, doctor Yawali.
Thank you very much. Good morning, everybody. Thank you to the organizers, the moderators. Thank you for the kind introduction. My task in the next 20 minutes is to give you an overview of esophageal disorders, approach to esophageal disorders in 2025. And we have some of the elements already discussed. History is very important. And Dr. Vela talked about transit symptoms, which are dysphagia, esophageal type regurgitation, and meal-induced chest pain. Sometimes these lead to weight loss and aspiration. When we talk about transit symptoms of this kind, it's important to think about some of these being sinister. In other words, a dangerous etiology, like a cancer. So some of these can determine how quickly you need to evaluate the patient. In other patients, they may have profound symptoms, and a few of them may have annoying symptoms. And as you heard, the starting point for much of these symptoms is to perform an endoscopy where you'll find many of these etiologies that I'm not going to go through in detail. In many instances, we take a approach to evaluate and treat motility disorders when the initial evaluation with endoscopy and or barium is negative, as Dr. Vela talked about. So if there is no explanation on endoscopy, a manometry study can identify a definitive achalasia diagnosis. One of the main reasons to perform manometry is to diagnose these actionable motility disorders like achalasia that we have definitive management for. So that's obstructive motor physiology. That's an obstruction of the outflow of the esophagus that we know how to treat. We disrupt, we cut, we tear the lower esophageal sphincter to make the patient better. All other patients, all other motility patterns need to be further evaluated according to what the patient's symptom is. If their symptom is a reflux-like symptom, manometry usually doesn't provide a whole lot of information, but there are some provocative maneuvers, there are some tricks with manometry that can bring out some of these disorders. We sometimes do multiple rapid swallows if the patient has hypomotility patterns. We do provocative maneuvers like the straight leg raised maneuver, and some of these patients need reflux monitoring. There are others who may have postprandial symptoms who have a behavioral disorder like supragastric belching, rumination syndrome, or abelchia, which can be made out by using another provocative maneuver called postprandial monitoring of manometry. Everybody else, the patients who have dysphagia-type symptoms, need to be assessed further for subtle motor obstruction. Why? Because we know how to treat obstruction. So upright swallows, doing a rapid drink challenge, giving the patient 200 ml of water to drink, or doing a barium study or flip, even in this setting, can bring out a conclusive outflow obstruction disorder that can be treated. Even in other patterns, a normal pattern or hypercontractile esophagus, distal esophageal spasm, if they have a transit symptom, manometry may not be enough, and you may need to do other tests. So there is value in doing adjunctive tests. Now, these days, we may have a situation where at that initial endoscopy, we have an opportunity to evaluate a motor obstructive pattern using FLIP. So with some of these symptoms, you could start with a situation where you could do FLIP. But if you find the cause during endoscopy, like we talked about in the first slide, you may not need to do a FLIP. If you find something, if you don't find something, there may be a scenario where you could do a FLIP. And you could use the findings on endoscopy to give you an idea as to whether you're looking for obstruction or not. And one of the scores that has recently been published is what's called the CAR score, that looks at esophageal dilation, stasis, resistance to pushing a scope through the EGJ, and scores these. And if those scores suggest achalasia, it's different from if the scores don't suggest achalasia. If the scores don't suggest achalasia and the FLIP is normal, if the opening of the esophagogastric junction is normal on FLIP, the likelihood of achalasia is very low. Remember, most of these evaluations are to find or treat obstruction. Everything else is treated symptomatically. On the other hand, if the FLIP shows obstruction and the endoscopy is suggestive of achalasia, then you might have your diagnosis right there. But look at all these boxes below the designations here. Even in these scenarios, there may be value to doing the adjunctive test. So if in the other scenarios where the tests are discordant, if the FLIP suggests obstruction, the endoscopy doesn't, you still need another test. And if FLIP is inconclusive, you need these other tests like barium and manometry. So having multiple concordant tests is very valuable. If you have endoscopy, you have manometry, barium, and FLIP all showing the same thing. If there is concordance between the tests, especially if there is 3-test concordance, then your confidence in an obstructive diagnosis or in absence of an obstructive diagnosis is going to be higher. And this is going to be particularly important in scenarios where a typical achalasia pattern is not seen on manometry, like the EGJ outflow obstruction. So in those patients with outflow obstruction, dysphagia symptoms, some obstructive pattern on manometry, if you have a FLIP that shows obstruction, those patients are the ones that will improve with achalasia-like treatments. You can see at the bottom, 77% of the group with outflow obstruction who had an abnormal FLIP improved with achalasia-like treatments. If they did not have obstruction on FLIP, they did not need these achalasia-like treatments, and they got better with conservative management. So how do you address obstructive physiology? Medicines don't work very well. They have side effects, so we don't use them very often other than temporizing measures. Botox, botulinum toxin, has temporary value. It can be used in poor surgical risk elderly as a therapeutic trial. Sildenafil can relax the muscle of the esophagus in these obstructive syndromes, but the outcome, the symptom outcome is not great. So we usually go to some kind of disruption, pneumatic dilation, surgical myotomy, or these days a per-oral endoscopic myotomy, which has been used very effectively, especially in type 3 achalasia and these spastic disorders where there's a lot of obstruction in the esophagus. You can do a tailored myotomy and get the patient better. What about perceptive symptoms, typical reflux symptoms, or atypical reflux symptoms? I'm not going to go into the atypical, but most of the time these symptoms can be profound or annoying. They're rarely sinister. And we usually start in the patients with typical symptoms without alarm by using a trial of an acid suppressant. And we do this because in the heartburn type presentations, typical presentations, the number needed to treat for a response, the column to the right tells you that if you treat 2 patients, one of them is going to respond. The number needed to treat is relatively slow. As the symptoms get more profound, chest pain or regurgitation, the number needed to treat for a response increases, and that's where investigation may be of value. In atypical symptoms, the number needed to treat for a response is so high that it's better to test first and then treat, rather than treat first and test those who don't get better. So what we're looking for in these patients is GERD evidence. You could find it on endoscopy. If you don't, you may need reflux monitoring study to figure out if reflux exists. And so testing is done off therapy. We have 2 options, wireless or catheter-based, and the idea is to identify or rule out GERD. And these are some of the features on reflux monitoring that could give you a diagnosis of conclusive GERD. Now, let's say a patient has conclusive GERD, then you are evaluating them if they continue to have symptoms to decide why they're not improving with the management you're providing them. So those are patients with proven GERD, and you test them on therapy with pH impedance monitoring. That's your only test that you can do. And the idea is to identify or rule out refractory GERD. So this is the Lyon consensus that puts all of this information together. Conclusive evidence for pathologic reflux. And if you find this, you're going to optimize reflux management. You're going to make sure the patient takes their PPI correctly. You can consider a new class of agents called potassium competitive acid blockers, or PCABs. There is one available here called tegoprazan. And so you optimize reflux management. Not all PPIs are made the same. They have different potency. It may be useful to go up the potency ladder if a patient doesn't respond to one PPI, if PCABs are not an option. If the patient does not have reflux, evidence against conclusive reflux, those are the patients where you can de-escalate the PPI, maybe wean them off, and use other types of treatments. Many of these patients have behavioral disorders or hypersensitivity. In patients with proven GERD, the Lyon consensus also gives you criteria for refractory GERD because you're testing them on therapy. And those are the patients where you may escalate and optimize reflux management. And some of these patients may need escalation beyond medical management to an invasive option that we'll talk about in a second. On the other hand, in patients who have controlled GERD. In other words, they are symptomatic, you do the pH impedance study on therapy, you have some of these features. That means that their symptoms are not related to poor control of GERD. Their symptoms may be related to some other mechanism, and sometimes that is also a behavioral or a functional disorder. There are some confounders of a PPI response, patients who take PPIs. Suboptimal dosing, or the patient doesn't take their medicine correctly, doesn't take it before meals. That is one of the major reasons for a PPI not being effective, and that's how we try and optimize PPI dosing. Some patients may be rapid metabolizers. They may burn the PPI off quicker than it can take effect. Some patients may not be taking it because of fear of an adverse effect. Some patients may have regurgitation-predominant GERD. Their symptom may be regurgitation rather than heartburn. Those patients are difficult to improve with PPI, as can be seen here. The blue bars are patients who underwent magnetic sphincter augmentation, and their symptom response was much better for regurgitation than from increasing a PPI. Patients who have a large hiatus hernia or a disrupted barrier may need advancing to a mechanical therapy rather than acid suppression. And then the superimposed behavioral functional disorders. The patients who have these affect disorders like depression, anxiety, overlap with IBS, other functional disorders, usually have a worse response to acid suppression because the hypervigilance and hypersensitivity that comes with these functional disorders may be driving their symptoms. They may have a frank behavioral disorder like supragastric belching. Some of the belchers may be belching because of a behavioral disorder rather than GERD. And some of the regurgitators may be having rumination syndrome rather than GERD. If they don't have an acid-based disorder, they will not improve with a reflux-like management. It's important to recognize these patients. Now let's take a moment to talk about these potassium competitive acid blockers because they do provide an advantage over PPIs. They don't need to be administered around the meal because they're acid stable, no enteric coating needed. They don't need to be activated, so they can be taken at any time during the day. They can bind to acid producing proton pumps, dissociate from them, and bind other pumps, so they're more effective. PPIs, if they bind to a proton pump, they're done. That PPI molecule has been used up. Not so with PCABs. They have long half-life. They inhibit proton pumps effectively after the first dose. They control nocturnal acid breakthrough, and they're not metabolized by the same hepatic enzyme system as PPI, so even the extensive PPI metabolizers may have benefit from using potassium competitive acid blockers. So in erosive esophagitis healing, the PCABs have a clear advantage, especially in LA grade C and D esophagitis. There is definite gain over PPIs. Now, what about heartburn relief? The studies that look at heartburn relief in the context of negative endoscopy mostly compare the agent to placebo and not head-to-head. But you can see that the signal is there for a higher degree of symptom relief even in these uninvestigated patients. Now, the best results are achieved with acid suppression if you can document that acid is causing symptoms. In other words, a positive pH study and not just heartburn with negative endoscopy. And there, the PPI benefit, the modern definition of NERD, the PPI benefit is quite high. It's quite possible that if these studies are done, I know they are being done here in Mexico, we don't have the results yet, the results with the PCAB could be higher than with the PPI, we don't know yet. So PCABs are an option for GERD management in advanced esophagitis, patients who are not good candidates for anti-reflux surgery, patients with motility issues, persistent symptoms for on-demand or preemptive use, especially reflux symptoms in patients who have proven GERD. They may also be of value in certain other settings like hypersecretory states, Barrett's after ablation, GI bleeds, and so on. What about inconclusive GERD? We talked about conclusive GERD and no GERD. So if there are borderline or inconclusive features, what you're trying to do is trying to decide if you have confidence that these patients with inconclusive features have true GERD. If they do, then escalation of GERD management could help them. How do we get there? We look at other features from the patient's evaluation. We can look at features from endoscopy or manometry, like a hiatus hernia, other reflux metrics, adjunctive metrics, or some of these symptom scores that have come out that can be useful in trying to make a designation as whether you're going to sway your impression towards true GERD. And in other patients, you may have low confidence in true GERD, and those patients may have an overlap with disorders of gut-brain interaction, especially if they have zero acid suppression response, or they have an intact esophagogastric junction, no hiatus hernia, low scores on those different scoring systems. These patients may have hypervigilance or disorder of gut-brain interaction as a mechanism. But in some patients, there may be value in escalating to anti-reflux surgery. It is well known from studies done many years ago that in well-characterized GERD, anti-reflux surgery has results equivalent to acid suppression. So in some patients, anti-reflux surgery is an option rather than a necessity based on patient preference and availability. There are other factors that need to be considered, including available expertise, comorbidities, and so on. In some other patients, it may be a potentially necessary situation. This was the results from a large study that was published in the New England Journal by Stu Speckler several years ago, who demonstrated that in refractory GERD, if you can document that reflux metrics persist on therapy in patients who are symptomatic, those patients do better with surgical management rather than continuing medical management. You have to make sure that you are treating GERD and nothing else. In some of these patients, you have to rule out a condition like achalasia. And in some patients, surgery is necessary in a large hiatus hernia. That red line at the top is patient satisfaction. You can see that the satisfaction is very high and reflux metrics go very low in patients with a true disruption of the EGJ with symptoms, chest pain, shortness of breath, cough, and so on. But PCABs could change the equation in these lesser categories where patients might get better symptom relief and you may not need to escalate to anti-reflux surgery. So what are the invasive options? We talked about anti-reflux surgery, but there's also transoral incisionless fundoplication. If you have a good surgeon, good endoscopist who can do this, sometimes you can also combine this with hiatus repair. It helps regurgitation very well. Magnetic sphincter augmentation is being scaled back. We are not going to have this available as much all around the world, so not much to say about that. In obese patients, a gastric bypass may be of value, but do not send these patients for sleeve, as sleeve can increase reflux. There is also a new technique called reflux stop. This is a silicone ball that is implanted in the proximal stomach that keeps the LES in the stomach compartment, maintains the intra-abdominal location, and this may have promise. It is not widely available yet. It's only available in Europe. And then there are some of these other options like band ligation, mucosal ablation, and a radiofrequency application that can be useful for some patients as an invasive option. But then patients may have symptoms from hypervigilance because of certain fears that they may have. In the context of an esophageal trigger like reflux or bolus retention, in the setting of esophageal hypersensitivity that leads to an increased perception symptom behavior, especially if they have personality traits like anxiety or hypervigilance. This can influence their quality of life and their symptom reporting. So these are the patients who report symptoms all the time. And this kind of hypervigilance permeates all GERD phenotypes: functional heartburn, borderline GERD, true GERD, and whether or not they have symptom reflux association. So what's happening here? Patients are scared. They think their symptoms are awful. They're afraid. They have response patterns like tightening of the chest. They avoid social behaviors, increase healthcare costs, and it totally influences their life. So cognitive therapy can help these patients by restructuring their cognitions, by helping them with coping, by helping them relax so that they don't have these physiologic changes, and by controlled exposure to their fears, right? You can also use neuromodulators, and there are many classes of neuromodulators. This is just an overview of different agents that can be preferred or not helpful based on what their presenting symptoms are. And you can see that you have to look at the patient as a whole, not just their esophageal symptom, to decide which agent might be best for the patient. So in the end, what we try to do in evaluating esophageal disorders in 2025 is to try and see where in this spectrum of true reflux-like syndromes or obstructive syndromes the patient exists, and how much behavioral disorders and named DGBI they have. So you can differentiate them by symptoms and by evaluation. And eventually you want to offer them disease-specific management if you have high confidence in what their disorder is. And that could include creating an obstruction if they have a reflux-like syndrome, or disrupting the esophageal smooth muscle if they have an achalasia or obstructive type syndrome. Thank you very much.
Muchas gracias, Prakash, por esta brillante conferencia que nos ha resumido el conocimiento sobre los trastornos esofágicos de los últimos años, y que seguramente ustedes tendrán algunas dudas al respecto y lo discutiremos en la sesión de preguntas y respuestas. A continuación, tengo el honor de presentar al doctor Walter Chang. Él es el director del Centro de Motilidad Gastrointestinal, es profesor asociado de Medicina en la Facultad de Medicina de Harvard y es director de la Educación en Investigación Clínica en el Brigham and Women's Hospital de la ciudad de Boston. Bienvenido, Walter, y él es un experto en las manifestaciones extraesofágicas del reflujo y es obviamente colaborador y participó en el consenso de San Diego, que nos ha aclarado cómo manejar el reflujo laringofaringio. Adelante, Walter.
Thank you. Thank you for the introduction, and thank you very much for having me here. It's a great honor to have the opportunity to talk here. I'll be talking a little bit about laryngopharyngeal manifestations of reflux and how we come to a correct diagnosis and manage these patients appropriately. So first of all, why is this important? I think these are patients that we see more and more now in our clinic. A lot of patients have laryngeal symptoms, and many of them are given the diagnosis of laryngopharyngeal reflux. And when you look at our outpatient consultation, at least in the United States, up to 10% of patients that come to an ENT practice or GI practice were coming for these symptoms. And the cost of managing these patients and diagnosing these patients are really high, about 5 times the total cost you see in typical reflux. But the problem is there are many things that can cause these throat symptoms. The question is, how can we appropriately diagnose who has reflux and who does not? How does reflux cause these throat symptoms? Or actually, there are 2 different mechanisms. One is when you have very typical reflux that come up into the esophagus from the stomach. It might go up to the proximal esophagus. That might be compromised in the upper esophageal sphincter, leading to these reflux state being present in the back of the throat. It might cause microaspiration that gets in the airway, that can cause inflammation. This is what we call the reflux mechanism of how reflux can cause airway problems. There's actually also another mechanism that might be in play where there might be reflux coming up, but they don't tend to go to the proximal esophagus. The upper esophageal sphincter barrier is fairly intact. The reflux doesn't actually get into the throat, but it might trigger a central pathway or vasovagal reflex that lead to airway reaction, or maybe bronchospasm that lead to some of these symptoms. And this is what we call a reflex mechanism of how reflux can cause airway problems. One important aspect of distinguishing and diagnosing these patients is distinguish patients who have throat symptoms that may be related to reflux, but we're not really sure yet. These patients, we'll call them patients who have laryngopharyngeal symptoms. It could be cough, it could be hoarseness, it could be throat clearing, maybe some excessive throat mucus, or sometimes they might have sore throat or pain. They tend to be chronic, they should be fairly frequent. They may be related to reflux, but we're not really sure yet. We want to reserve the term laryngopharyngeal reflux disease to those patients who have these symptoms but actually have objective evidence of reflux that may support this relationship, so that we can actually manage these patients appropriately. Because if you look at the literature, you see that the term laryngopharyngeal reflux is being referred to for a lot of different patients, whether or not they have testing or not. To make sure that we're actually treating the patients appropriately, we want to make sure that we're actually labeling them correctly. How do we approach these patients? Well, first of all, you have to think about how you approach typical reflux symptoms. Dr. Gorali kind of mentioned some of the general approach that we have, including starting with conservative management, diet, lifestyle modifications, maybe empiric acid suppression therapy. If they don't respond, you might think about doing an upper endoscopy, and you proceed to objective testing. And if there's evidence of reflux, you might think about surgery or escalating treatment. But does this paradigm, does it work for extraesophageal reflux symptoms? Well, first of all, we want to look at how patients with laryngopharyngeal symptoms respond to empiric PPI trial. Unfortunately, the data have shown that the response have been quite suboptimal. The benefit is quite marginal in meta-analyses, and there was actually a recent randomized trial to compare twice-daily lansoprazole with placebo, and they found that there was no difference in the symptom outcome. So perhaps empiric PPI trial is not that effective for these laryngopharyngeal symptoms. Can we use symptoms to direct management? When patients come in with their throat symptoms, can we distinguish them? Well, it turns out that these presenting symptoms are very widely variable. And when we did a study that we tried to look at how these symptoms predict abnormal reflux on testing, we found that the symptoms actually do not predict abnormal reflux very well at all. And even if you use some of the symptom indices, like the reflux symptom index, the sensitivity and specificity are not that great. So we know that clinical symptoms alone are not really sufficient to make the laryngopharyngeal reflux disease diagnosis. And one of the reasons is that there are actually many different phenotypes of these patients that come in with throat symptoms. This is a study that we did where we tried to look at over 300 patients who came in for testing, and we look at the clinical characteristics and see if there are different phenotypes of patients. It turns out that there are 5 different clusters or phenotypes of patients that we found, including patients who have very objective evidence, clear evidence of reflux, patients who may have some marginal reflux, and there are 3 groups of patients that don't really have true reflux or a very marginal amount of reflux at all. And one of the things that you can see is that in the group of patients who have evidence of reflux, they tend to have more typical symptoms, but not the other group. And when you look at how prevalent they are, you can see that the group with no reflux is actually the most prevalent group. So perhaps we're looking at 2 different types of phenotypes here, those that are more predominantly having true reflux and those patients who have more non-reflux type phenotype. And one of the things that we can try to do is, can we predict who might be belonging to the reflux or non-reflux phenotype to help direct diagnosis and management? When we think about PPI response, we talk about, maybe the response is not that great. But especially when you look at patients who come in with these laryngopharyngeal symptoms and they're uninvestigated, they're just coming in with symptoms, they put them on a PPI trial, you can see that the number of needed to treat here is basically infinity, meaning that there's no benefit. But if you actually test patients and you only treat patients with objective reflux, then the benefit is more significant. You can see that there's significant improvement in how PPI actually, how well it works in these patients. So perhaps the key is to only treat patients who have actual evidence of reflux and not all patients coming with throat symptoms. And there's actually been cost studies too that have actually even looked at this from one of my collaborators a few years ago when they looked at the cost of trying to treat patients first or test patients first. And they found that it's actually more cost saving if you actually test patients before you put them on a PPI rather than empirically treating everyone with the throat symptoms with a PPI. How about laryngoscopy? A lot of our ENT colleagues do these. They send the patients to us because they're evidence of reflux, as they say, on laryngoscopy. It turns out these findings that were suggestive of laryngopharyngeal reflux on laryngoscopy cannot really diagnose LPRD. There have been very poor correlation between these findings and symptoms or even treatment outcome in these patients. And one of the reasons is that these changes that they look for in laryngoscopy are just very non-specific irritations. They're not, anything can cause these kind of irritated throat. In fact, there have been a study where they took healthy volunteers and make them undergo laryngoscopy. They found at least one of these signs in up to 87% of these healthy volunteers. So you can see how non-specific these findings are. So laryngoscopy is useful because you want to make sure there's no other things like cancer, but it's not really useful to diagnose LPRD per se. How about endoscopy? Can we use endoscopy to help us? Well, it turns out that maybe we can find signs on endoscopy that may suggest reflux. In this multi-center study that we did, we found that up to almost 50% of patients might have some objective evidence of reflux on endoscopy for these laryngopharyngeal symptoms patients. So perhaps endoscopy might give us a clue. There are also these in-office transnasal endoscopy that some ENT providers are trained in doing, so they might be helpful too in screening for esophagitis or Barrett's. There are also these gastric inlet patches that we sometimes see during endoscopy in the proximal esophagus. There have been some studies that have shown that they may be associated with more laryngopharyngeal reflux type symptoms, and there have been some very small case series where if you ablate these gastric inlet patches, the symptoms might improve. There's no control trials yet. There's one that's ongoing, but there's no data yet, but hopefully we'll have more data to support that. But maybe this is one of the ways we can manage these patients. So perhaps endoscopy is useful because sometimes we can actually find conclusive or adjunctive evidence of reflux on endoscopy. How about esophageal motility testing? It turns out that a lot of these patients might have some evidence of esophageal dysmotility. This is a study that we did of about 200 patients where we tried to look at their findings on high-resolution manometry. It turns out that almost 40% of them had some type of abnormal findings on manometry. Most commonly is ineffective esophageal motility, so they're very associated with reflux to start. But we actually found about 6 of them had some type of either outflow obstruction or major peristaltic disorders. So maybe motility testing will also be useful if you think about testing these patients. And there are also some findings on manometry that we've found that may be supportive of a diagnosis of laryngopharyngeal reflux disease or maybe correlate with worse outcome, like increased failed swallows, if there's large peristaltic breaks, also if there's some proximal esophageal or upper esophageal sphincter abnormalities, that may help you, give you some clues that it might be playing a part in their symptoms. How about reflex monitoring tests? These are sort of the more gold standard that we currently have. And there are different types of reflex monitoring tests available. The wireless pH test, where we test for distal esophageal pH, the 24 hours pH impedance study, and also there's another variation that we can sometimes use for these patients with throat symptoms, which we call hypopharyngeal and esophageal impedance pH testing. It's very similar to a regular pH impedance catheter, except that sensors are located slightly differently. So there's actually impedance sensors that are located, you put them right around the upper esophageal sphincter area. The advantage of this is that you can actually see reflux episodes that go from the distal esophagus up to the proximal esophagus and up to the pharyngeal region to look for pharyngeal reflux events. So how do you choose between these? We understand that a wireless pH study, you can do a more prolonged study up to 96 hours, or the 2 other catheter-based tests generally do them for 24 hours. You should almost always do these patients off PPI because you're trying to look for true evidence of reflux because these are usually unproven yet. Placement for the wireless pH, you need endoscopy to help you. The other two catheter-based tests, you require manometric guidance. What are some of the metrics that we look for? There are basically conclusive evidence of reflux, such as increase in acid exposure time greater than 6%, or for at least more than 2 days on the wireless pH test. There are also supportive evidence, including on the wireless test, AET greater than 6% or at least 1 day. And for the two catheter-based tests, if you have a high number of total reflux episodes on impedance, greater than 80 total episodes, or for the pharyngeal catheter, if you have more than 10 pharyngeal reflux episodes on the catheter. There are also exclusionary evidence for reflux, including having a low acid exposure time, less than 4%. What are some advantages? How do you decide between these? Obviously, the wireless pH monitor, the patient is more comfortable, there's nothing sticking out their nose. You can do a more prolonged assessment, so it increases your sensitivity. For the two catheter-based tests, you have additional information, including more non-acid, both acid and non-acid reflux. You can look at proximal reflux because you have proximal impedance sensors. And for the hemi-pH catheter, you can even get pharyngeal reflux event data. So you get additional data for that. But there's also a disadvantage for each one of them. Wireless pH monitor, you can only get acid reflux data. You can't really get proximal data, so it's hard to link their symptoms to a proximal reflux physiology. For the catheter-based test, obviously it's uncomfortable with the catheter sticking out of their nose. Because of that, you generally can only do it for 24 hours, so you might lose some of this sensitivity to day-to-day variation of reflux. And for the hemi-pH catheter, the normative cutoff of pharyngeal reflux is not really well validated yet, so that might create some limitation in interpretation. What are some other testing modalities that are available? There's this nasopharyngeal only pH monitor, which is what a lot of the our ENT colleagues do. It's a pH catheter that you place into the nose with the pH sensor just sitting in the back of the throat. It can only give you information on pharyngeal pH. There's no impedance information. The problem is that this technology tends to have really weak correlation with pH impedance finding when they do concurrent testing. So a lot of times they will see pH changes in the throat, but there's actually no reflux happening in the esophagus. So many things can cause pH changes in the throat. They can't really distinguish between patients with reflux disease and healthy volunteers. Definitely couldn't predict response to PPI. So really not adequate to diagnose LPRD, which is this nasopharyngeal pH monitor. There's other testing that's been developed, including pepsin testing in the saliva. So the idea is that if you see pepsin in the saliva, maybe it's a marker for laryngopharyngeal reflux disease. And there have been some studies that have shown that these concentrations of salivary pepsin is higher among patients with both laryngeal symptoms and reflux symptoms compared to healthy volunteers or patients with isolated laryngeal symptoms. But the problem is when they categorize these tests based on positive or negative results, the proportion of positive tests didn't really correlate significantly. They're not significantly different between these groups. So they're not really couldn't really distinguish among these different patient phenotypes. So maybe it could be a useful adjunctive test, but definitely is not useful right now as a standalone test for diagnosing laryngopharyngeal reflux disease. Do we have to test everybody? That's always one of the questions. And there's some newer data now on some prediction score that may help us stratify the risk for reflux for these patients. And one of these is this cough reflux score. We developed this among 5 centers internationally. We try to see if we can stratify patients into having high, medium, or low risk of laryngopharyngeal reflux disease. The idea is that for patients who are high risk, maybe you can start empiric treatment. Patients who are low risk, you can think about treating for other causes of throat problem first and not think too much about reflux. And really only the middle group where you have medium risk, those are the patients you think about testing first to direct treatment. And this score has been shown to be helpful, had high sensitivity and specificity in predicting reflux and also predicting proximal and pharyngeal reflux. And there have also been some data now that maybe it's useful to help predict treatment response as well based on how you classify these patients. So perhaps a risk score like this will be useful in directing management for these patients. So when you think about how you approach these patients, you think about First of all, maybe thinking about whether or not they have esophageal symptoms. For patients that have esophageal symptoms together with their laryngeal symptoms, you can think about treating them first. If they don't respond, then definitely test them before thinking about further treatment. If they respond, then you know that they likely have laryngopharyngeal reflux disease or an overlap with a regular GERD, and you can continue treatment. If you think about escalating therapy for these patients, definitely do an objective testing first. And if you have only isolated laryngopharyngeal symptoms, meaning that they don't have esophageal symptoms, maybe you want to test them first before you actually treat them. Obviously, when they test positive, you can think about doing treatment or even escalating reflux therapy. So we talk about there are many causes of laryngopharyngeal symptoms, right, including GERD, but there are other things that might lead to these symptoms as well. Maybe airway problem, oropharyngeal dysphagia, vocal cord problems, lung problems that can cause these issues. Diet or medications can lead to some of these laryngopharyngeal symptoms, for example, ACE inhibitors. Allergies, sinus issues can lead to a lot of these symptoms as well. Maybe some changes in sensation within the throat. Hypersensitivity can also lead to some of these symptoms. And that's why we need to also think about other evaluation and management outside of reflux for these symptoms. For example, look for medications can commonly associate with symptoms like cough and discontinue them. Look for food allergy triggers. Think about doing evaluation for oropharyngeal swallowing, maybe assess their vocal cord by the ENT colleagues. Doing allergy and sinuses assessment with our ENT colleagues, maybe do allergy testing. Maybe a trial of antihistamine might be useful for some of these patients for their allergies. And also think about underlying pulmonary conditions. But one important aspect of this probably hypersensitivity or brain laryngeal disturbances that sometimes can cause these symptoms. There have been some studies that have shown that patients with both GERD and laryngopharyngeal symptoms are more likely to have psychological distresses or other functional GI problems. And when looking at esophageal hypervigilance and symptom-specific anxiety, these seem to be higher among patients with laryngopharyngeal symptoms compared to those without laryngopharyngeal symptoms. And in fact, when you look at these hypervigilance and anxiety, it seems to be very prevalent among patients with laryngopharyngeal symptoms, regardless of whether or not they have reflux. So perhaps these brain laryngeal disturbance may play a role in these symptoms, and maybe this is a target for therapy. And what are some of these, and how does this work? Perhaps patients can have local irritation to their throat. If they already have hyperresponsiveness, they might start having throat tightness and tension. If they have hypervigilance and anxiety, they may have increased awareness to these symptoms. And with these hypersensitivity, because they're already more aware, they're more likely to sense these symptoms, and then they start reacting to it by tightening their throats more. So it becomes a cycle that continue to worsen the symptoms. So can we, when we think about these symptoms, these patients with laryngopharyngeal symptoms, then we should really take into account this possible role of laryngeal hyperresponsiveness and hypervigilance, and perhaps treating these may also help patients' symptoms. And how do we actually treat them? Well, there are actually a number of different ways of treating them. You can think about using neuromodulators, maybe cognitive behavioral therapy would be useful for these patients, other psychological therapies, or even vocal cord recalibration therapy to help the patient with these brain laryngeal disturbance type symptoms. The key to this is that because we know that there are many things that can cause throat symptoms, is to have an integrated, personalized care. You can't just treat reflux alone, but you have to think about all the other causes, and some patients may need treatment for all these other causes together to help them, their symptoms improve. So the key is that we talk about if they have laryngopharyngeal symptoms, if they have reflux, treat their reflux. If they don't have reflux, think about evaluating and managing for other causes. Always think about psychological factors and brain laryngeal disturbances, and maybe treat them with behavioral therapy or neuromodulation, and always take into account other causes of symptoms and try to manage those other etiologies. So we know that laryngopharyngeal reflux symptoms, laryngopharyngeal reflux disease are challenging because there's no real diagnostic gold standards, and a lot of times the symptoms are very nonspecific, including patients who have no esophageal symptoms. So, really think about how you want to approach these patients in a multidisciplinary manner. Laryngoscopy is not adequate in diagnosing or ruling out LPRD. Consider upfront testing before PPI trial, especially for a patient with isolated laryngopharyngeal symptoms. Maybe use risk stratification tool like the cough reflex score. Escalate therapy really only if you have objective evidence of reflux. And think about brain laryngeal disturbances because they may play a role in their symptoms, whether or not they have true reflux. And think about integrating the other discipline and treating all the other factors and not just reflux alone. Thank you.
Doctor Chan, muchísimas gracias por su brillante conferencia. A continuación, el doctor Ronnie Fass, conocido por todos nosotros. El doctor Ronnie Fass es el director médico del Centro de Salud Digestiva y jefe de la División de Gastroenterología y Hepatología y del programa de deglución y esófago en el Metro Health Medical Center en Cleveland, Ohio. Además, es profesor de medicina en Case Western Reserve University. El doctor Ronnie Fass nos va a hablar de dolor torácico de origen esofágico. Muchísimas gracias, doctor Ronnie Fass.
Thank you very much. Great pleasure for me to be here. We can start. There will be. So the topic that I'm supposed to cover is esophageal chest pain. And let's learn a little bit about chest pain when it comes from the esophagus. So first of all, as you all know, the esophagus has a very limited repertoire of symptoms. If you think about, there aren't many of them. Definitely chest pain is one of them, and it's very important to recognize it and know how to treat it. The other thing that you have to know about chest pain that comes from the esophagus is that it's not stimulus specific. So there are many different intraesophageal stimuli that can lead to chest pain. They could be mechanical, like balloon distension. They could be chemical, like acid exposure, thermal, and there were even studies where they used electrical stimulation in the esophagus, and they were able to show that patient can develop chest pain from that. The other thing you have to know, heartburn is a type of esophageal chest pain. Remember that. Now, when you look at the relationship between heartburn and chest pain, we can see that some patients develop heartburn from gastroesophageal reflux, solely, just heartburn. Then we have other patients that develop solely, just chest pain from gastroesophageal reflux. And there's also, we have patients that develop heartburn from gastroesophageal reflux sometimes, and chest pain other times, in the same patient. Now these findings suggest that heartburn is a type of esophageal pain, although when it comes to practice, esophageal disorders, we somewhat separated the two. Now, when you look at different pathophysiological mechanisms for esophageal chest pain, then we have several of them, which obviously suggests that we don't know what exactly caused chest pain in patients. There are mechanisms like patients with very low reflux, pH, refluxate with very low pH and over longer duration. Patients that demonstrate that during esophageal muscle contractions, there is a significant reduction in blood flow into the muscle, and this is what we call the local ischemia model that can lead to chest pain. There are studies looking at the longitudinal muscle, the outermost muscle of the esophagus, that is involved in the process of esophageal contraction and sustained longitudinal muscle contractions can lead to chest pain. Patients with esophageal chest pain has been shown by some studies to have a stiffer esophagus, and the esophagus is hyperreactive, resulting in hypercontractility. There are also studies demonstrating that there is a decrease of blood flow in the coronary circulation as a result of gastroesophageal reflux through the vagal reflex that Dr. Chen just mentioned. So that can also affect the circulation of the heart, leading to ischemia of the heart as part of the chest pain, what we call link angina. One of the things that we see in all patients that present with functional esophageal disorders or esophageal disorders of gut-brain interactions, that they all demonstrate esophageal hypersensitivity. And that means that these patients are sensitive to low-intensity stimuli. That means that what drives these patients to develop symptoms to a certain stimuli does not have any effect in normal subjects. And this is usually due to peripheral or central sensitization. Now, how heartburn and chest pain are affected here by these type of pathophysiological mechanisms? Then several of these pathophysiological mechanisms suggested that lower intensity or shorter duration of stimuli lead to heartburn. But the same stimuli, if they are in higher intensity or longer duration, they will result in chest pain. How common is non-cardiac chest pain that is not from the heart? We can see globally that it ranges from 14 to 33%. So it's relatively common, but these studies looked at patients that experienced chest pain at least once during their lifetime. There is this meta-analysis that was done by Alex Ford, and he found out that globally it appears that the prevalence of chest pain is about 13%. Now, you have to remember there are many mechanisms that can lead to chest pain or non-cardiac chest pain. They include pulmonary, pericardial, they can include musculoskeletal, panic disorder. Panic disorders drives about 25% of the patients that show up in the emergency department with chest pain, 25%. And there are other GI disorders that can result in chest pain. They include gastro and pancreatic disorders. Gastric and biliary and pancreatic disorders. But when we look at esophageal disorders that lead to chest pain, by far, gastroesophageal reflux disease is the most common cause. Remember that. Now, for a long period of time, we used to call esophageal chest pain as atypical chest pain, but I think the Montreal Consensus meeting made a difference in that regard, where they decided to use chest pain as a typical symptom of gastroesophageal reflux disease. And as you can see here, they stated that chest pain is reflux chest pain syndrome is one of the symptomatic presentations of gastroesophageal reflux disease. So studies have shown, and the range is huge in many of these studies, erosive esophagitis, I found out between 10 to 70% of the patients that present solely with chest pain. Esophageal acid exposure between 50 to 60%. But one of the things that you have to understand, we can have a patient with chest pain and document with objective evidence of gastroesophageal reflux disease, erosive esophagitis, or abnormal esophageal acid exposure, but the question is, are they the underlying cause of this patient chest pain? And the studies have shown that if patients with chest pain have objective evidence of gastroesophageal reflux disease, as was mentioned at the top, then response to PPI treatment reaches 80%. That means that if you have this objective evidence in patient with esophageal chest pain, it is highly likely that GERD is the underlying cause. The least common cause of esophageal chest pain, interestingly, is esophageal dysmotility, affecting about 15 to 18% of the patients that show up with esophageal chest pain only. Now, this is a study that we published where we actually showed a few things when you come to analyze patients with non-cardiac chest pain. First of all, we found out that esophageal chest pain was one of the most common causes for referral of patients for esophageal manometry. The second one, the most common finding in this patient population, maybe to your surprise, was a normal esophageal manometry. By far, the most common. There are some studies suggesting it's up to 70%. And the next one, which is also probably very surprising, ineffective esophageal motility was the most common motility disorder that was identified in this patient population. Not distal esophageal spasm, not hypercontractile esophagus. They were actually in the 3%, 2%. But ineffective esophageal motility disorder was the most common one. And then we have functional chest pain, which is relatively common as an underlying cause for non-cardiac chest pain, could be affecting up to a third of these patients. Now, this was defined, and obviously we're going to have a new definition coming up as part of Rome 5, but we still need to talk about Rome 4, as retrosternal chest pain or discomfort, and there's no evidence of associated esophageal symptoms such as heartburn and dysphagia, no evidence of gastroesophageal reflux disease, eosinophilic esophagitis, and absence of major esophageal motor disorders except ineffective esophageal motility. Now, the Rome Foundation has a task force, the Rome Foundation Global Epidemiology Study, and they've been looking at the prevalence of many disorders of gut-brain interactions around the world, and they also looked at esophageal disorders. And you can see that in Asia, EDGBIs affect about 4% of the population. In Western Europe, it's about 6%. If you look specifically at esophageal disorders of gut-brain interaction, functional chest pain is the second most common after functional dysphagia. And it's about in the range in Asia between 1 to 2%, and in Western Europe between 2 to 3%. So how do I work up a patient that presents with chest pain? So if you have a patient that presents with chest pain, then first you need to take a good history and evaluation and determine, is this chest pain related to the esophagus, or it is related to many other reasons that can lead to chest pain. I mentioned pulmonary, pericardial, musculoskeletal, many other reasons. Now, if you excluded that, then the next thing, the most important thing, and I need to emphasize this as gastroenterologists, you have to rule out a cardiac cause. And I don't care how old is the patient and if the patient has risk factors or don't have risk factors, I think you have to make sure that they don't have a cardiac cause for their chest pain. If they don't have a cardiac cause and they don't have an alarm symptoms, then one should consider the use of empirical treatment with a PPI or a PCAB. And obviously, if they do respond, that tells you you're dealing with the most common cause of esophageal chest pain, which is gastroesophageal reflux disease, and then you can taper down to the lower dose that control their symptoms. Now, this is the use of the PPI test as a diagnostic value in patients with non-cardiac chest pain. And in fact, it does show good sensitivity of about 80% and specificity, both about 80%. Now, if the treatment that you offer the patient is not working, then it's time, if it wasn't done, an upper endoscopy, and I would add also in the proper patient population, if those that have also a component of dysphagia, biopsies to rule out eosinophilic esophagitis. Now, if you take thousands of patients that present with non-cardiac chest pain, what are you going to find on their upper endoscopy? Most of the studies show the same thing. Most of these patients will have findings that are consistent with gastroesophageal reflux disease, like Barrett's esophagus, erosive esophagitis, hiatal hernia, and others. Very rarely you will find eosinophilic esophagitis in these patients or cancer. So then, if the upper endoscopy is unremarkable, then you should consider at this point reflux testing, and I would do it in this patient population of PPI or PCAB if there's no evidence of gastroesophageal reflux disease, and I would also add manometry at the same time. If there is no evidence of abnormality on the reflux testing or the manometry, on the reflux testing, then you look at the manometry, and if there's no abnormality there, then you're looking at functional chest pain, except ineffective esophageal motility, which is still allowed as part of diagnosis of functional chest pain. Now, if there is abnormal esophageal acid exposure, then you're dealing obviously with GERD. If there is normal esophageal acid exposure, but there is a positive correlation between symptoms and reflux events, the chest pain, then you're looking at reflux hypersensitivity. Remember, reflux hypersensitivity can show a correlation between symptoms and heartburn or chest pain and abnormal reflux. So it's not only heartburn. And then, if the motility test is positive, then you have a major motor disorders, again, except IEM. So how do we treat patients with chest pain? If they have GERD-related esophageal chest pain, then the options are obviously anti-reflux medications, and I would not consider any medication except PPI and PCABs. No H2 blockers, no others, no Gaviscon, no antacids. Or in very selected patient population, you can consider endoscopic or surgical intervention for gastroesophageal reflux disease. This is a meta-analysis that showed that PPIs work very well in patients with GERD-related chest pain, as I mentioned, preferably with evidence, objective evidence of gastroesophageal reflux disease. The studies have shown that you can treat this patient for 2 months, but some of the studies suggest that you may need double-dose PPI. Here are a list of studies that looked at anti-reflux surgery in this patient population or the use of endoscopic therapy. Now remember, these studies, they selected very carefully their patient population. So when you look at these very positive results, you have to take it obviously with a grain of salt because of this very high selection of patient population. But at least they demonstrated in the right patients, they do work. What about treatment for motility-related esophageal chest pain? Now remember, most of our patients will have ineffective esophageal motility, and in these patients, my belief is that many times it is associated with gastroesophageal reflux disease, so you will address it through your treatment of gastroesophageal reflux disease. In those that tend to have more spastic disorders, then you can consider muscle relaxants, nitrate, calcium channel blockers, and sildenafil. The only thing I can tell you about these is that they may be associated with side effect, they may or may not work, and sildenafil is another way to give the patient, in addition, also bad gastroesophageal reflux. Botox injection in subset of patients. Neuromodulators, I have to tell you, those have been underused in patients with spastic esophageal motor disorders or even in patients with achalasia. I think they do have a role. Pullman surgery, obviously, in patients with achalasia or patients with spastic motility disorders or EGJ-OO. I have to show this study. It's a very old study, but it's done by the great Ray Klaus, and he was the first one to show that neuromodulators work very well in patients with spastic esophageal motor disorders. And in this case, he used trazodone at the time, a tetracycline. What about functional chest pain? Neuromodulators probably will be one of the mainstay of treatment, psychological intervention. And there are a variety of alternative and complementary medicine that have been reported in the literature. And by the way, you can combine all three if you wish in this patient population. This is the most recent kind of summary of all the randomized controlled trials of neuromodulators in patients with esophageal disorders of gut-brain interaction. And you can see many of them, or most of them, were done in non-cardiac chest pain or functional chest pain. It could be tricyclic antidepressants, SSRIs, SNRIs. There are studies looking at trazodone, as I mentioned, gabapentin, theophylline. I would be very careful because of potential adverse events, pregabalin, and many others. Now, when it comes to tricyclic antidepressants, you have to remember, we have the tertiary amines. These are tricyclics that have high affinity to their respective receptors. You can see the receptors at the bottom. That means that they will likely be more associated with side effects. The secondary amines have less affinity to their respective receptors, and so they're less likely to be associated with adverse events. That include nortriptyline and diazepam. Now, you have to remember also that tricyclics may take time to show an effect in your patient, 4 to 6 weeks. So if patient calls you after 2 weeks, you have to tell them you need to wait. An initial treatment, 10 to 50 milligram, you can potentially go to 150 milligram, although I personally keep it low. There is even data about dronabinol, which is a cannabis derivative, although more studies are needed. And behavioral therapy is very important in functional chest pain. Here are different types of behavioral therapies, although hypnotherapy and cognitive behavioral therapy are the most commonly that have been used and have very good data to support them. Recently I've seen many studies looking at the role of diaphragmatic breathing and other relaxation technique. Like on the left side, you can see the Jacobson relaxation technique, and you can see how you can do it. On the right side, there is the neuromuscular stabilization, which is another. These are a bunch of exercises, so hopefully your patient can do them. The Jacobson is not bad. The other one is a little bit labor intensive. And then last but not least is alternative medicine for functional chest pain. There is evidence to support the use of Joray. It's an energy healing approach that has been shown to improve patients' symptoms. The Asford capsules include these two beautiful flowers that not only you can smell them, but you also can make a potion or a pill out of them, and apparently they can help your chest pain. This is actually the Joray study where patients were randomized to Joray energy healing as compared to waitlist, where they were told that after 6 weeks they will get some treatment, and during that time they documented their symptoms, and you can see the Joray intervention did better than the waitlist. Thank you very much. This is my last slide, and this is, by the way, a real book, and I need the money. Thank you.
Y como siempre, excelente presentación. Y la última presentación, tengo el gusto de presentar al doctor José Alberto Arenas Martínez. Él fue gastroenterólogo y neurogastroenterólogo egresado del Instituto Nacional de Nutrición. Es de nuestros jóvenes valores, y él fue receptor de la beca de perfeccionamiento en gastroenterología de la Asociación Mexicana de Gastro, y él actualmente está haciendo una fellow de investigación en la Clínica Mayo en Scottsdale, y bueno, nos va a hablar sobre enfermedad, la esofagitis eosinofílica en el 2025, una revisión actualizada. Y felicidades por estar aquí, José Alberto.
Muchas gracias por la invitación y la tan amable introducción. Y en los próximos 15 minutos vamos a hablar sobre esofagitis eosinofílica en el 2025. Y el objetivo de esta plática es poder discutir las actualizaciones y las guías más recientes de esofagitis eosinofílica, así como responder 3 preguntas que son cómo integramos las alergias tanto en el diagnóstico y el tratamiento de esta enfermedad, por qué clasificar la severidad en diferentes aspectos de la esofagitis eosinofílica y cuándo realizar endoscopía de control. La esofagitis eosinofílica es una enfermedad esofágica crónica inducida por alergenos y mediada por inmunidad del tipo 2, que en otras palabras lo que significa es que aeroalergenos del ambiente y principalmente alergenos de los alimentos penetran una barrera epitelial disfuncional en el esófago e inducen una respuesta mediada por linfocitos T ayudadores del tipo 2, con una cascada inflamatoria que su expresión es el infiltrado predominantemente eosinofílico del epitelio esofágico, caracterizado por criterios diagnósticos con más de 15 eosinófilos por campo de alto poder y que se manifiesta de forma clínica como síntomas de disfunción esofágica. Ahora existen diferentes factores de riesgo para la esofagitis eosinofílica, las principales, las enfermedades atópicas, antecedentes familiares de esta misma enfermedad y algunos factores genéticos que principalmente están relacionados a problemas de la barrera epitelial esofágica y no solamente esofágica, sino también de la piel. Ahora, está claramente demostrado que los pacientes con esofagitis eosinofílica tienen una mayor frecuencia de diferentes enfermedades atópicas, como son las alergias alimentarias de diferentes grupos de alimentos, asma, rinitis alérgica y dermatitis atópica. Las manifestaciones clínicas de la esofagitis eosinofílica variarán de acuerdo a la edad de presentación en los pacientes. Y es que en los infantes jóvenes o lactantes pueden presentarse como dificultad para el alimento, rechazar los alimentos, vómito, retraso de crecimiento, fallo en medro o pérdida de peso, y en adultos jóvenes y adolescentes como dolor abdominal, vómito, regurgitación y clásicamente en los adultos como disfagia e impacto del bolo alimentario. Así como en algunas ocasiones, aunque como menor frecuencia, y ya fue mencionado, como pirosis y dolor torácico y ocasionalmente con regurgitación. Ahora, ¿qué sabemos de estos síntomas en hispanos en nuestra población? En datos que estamos en proceso de publicar en los próximos semanas o días, sabemos que en una cohorte de niños hispanos en Phoenix, en comparación a sus contrapartes no hispanas, era más frecuente que se presentara como fallo de medro o pérdida de peso, en comparación de otras manifestaciones clínicas en pediátricos, así como pirosis y dolor torácico en aquellos un poco más grandes, entre 16 y 20 años, en comparación de la predominancia de disfagia en otros grupos de esa misma población de Phoenix. Entonces, quizá la forma en la que los hispanos presentamos la esofagitis eosinofílica no es la clásica disfagia impacto alimentario que frecuentemente leemos en los artículos o textos. Esperemos que esto lo podamos publicar ya en los siguientes días. Ahora, los pacientes no siempre, en los adultos no siempre se presentan con pérdida de peso, y esto es porque los adultos nos adaptamos a poder mantener la ingesta calórica y nutricional a través de diferentes conductas de adaptación, que en la inglés se utiliza el acrónimo IMPACT, que es poder acompañar los alimentos con líquidos, y son pacientes que cargan agua a todos lados y siempre están con una bebida para acompañar sus alimentos, modifican la consistencia de sus alimentos cortando y triturando los alimentos de forma inconsciente, tienen tiempos de alimento prolongados y son las personas que son los últimos en levantarse de la mesa de la comida, evitan texturas duras de los alimentos como son las carnes o los panes, mastican excesivamente la comida y finalmente tienen dificultad para pasar las tabletas, y son pacientes que nos piden, no, yo no quiero tomar una pastilla o cápsulas. ¿Por qué? Porque nunca lo he podido deglutir, siempre me ha costado trabajo hacerlo. Como ya hemos visto, para la evaluación de síntomas de disfunción esofágica, el primer paso es realizar la endoscopía, y es importante que prestemos atención a realizar una adecuada evaluación sistemática y detallada de la mucosa del esófago, que eso significa tomar el tiempo para insuflar adecuadamente la mucosa del esófago, no solamente pasar a través del esófago y limpiar el moco y detritus para poder observar adecuadamente la superficie epitelial o la superficie de la mucosa. Y recordemos que nuestra sensibilidad como gastroenterólogos es bastante mala para detectar las estenosis del esófago. En comparación de otros métodos diagnósticos, nuestra inspección Simplemente con la endoscopía tiene una sensibilidad del 25% para detectarla. Entonces, siempre que tengan un paciente que sospechen síntomas de disfunción esofágica, tengan un alto índice de sospecha y hagan diferentes maniobras para poder evaluar verdaderamente el calibre del esófago. El paso del endoscopio no es suficiente para considerar normal ese esófago. Ahora, existen diferentes puntuaciones y actualmente la recomendada por diferentes sociedades es la puntuación de referencia endoscópica de la esofagitis eosinofílica, o EREF por sus siglas en inglés. Y esto son simplemente las siglas, ¿no?, de las principales características endoscópicas de la esofagitis eosinofílica, que es la presencia de edema, o sea, una disminución de la vascularidad de la mucosa, anillos, exudados y pliegues, así como estenosis esofágicas. Y los invito a que siempre que tengan un paciente que sospechan o que encuentran alguno de estos videos, documenten adecuadamente este score. ¿Por qué? Porque será bastante útil en su seguimiento. Otro paso importante en la endoscopía es una buena técnica y una adecuada toma de biopsias esofágicas, con una técnica de turn and suction, que lo único que significa es poder tomar una biopsia lo más grande posible y tomarla casi siempre a unos 4 o de forma distal, unos 4 centímetros de la unión, y hasta 14 centímetros para unas biopsias medio proximales. Intenten enviar siempre los frascos separados, por lo menos en la endoscopía índice, para poder tener también una perspectiva importante de los diagnósticos diferenciales de acuerdo al conteo de eosinófilos. Ahora, ¿qué sabemos respecto a la toma de biopsias en México? Bueno, en este estudio que hicimos en el Instituto de Nutrición y que recientemente publicamos, sabemos que, al menos en nuestro medio, tomamos pocas veces biopsias. Menos de una tercera parte de los pacientes con disfagia son biopsiados y más del 40% de los pacientes cuando se evalúan por disfagia están tomando IVP, lo cual probablemente nos está haciendo un infradiagnóstico de esofagitis eosinofílica en nuestro medio. Entonces, el tener protocolos sistemáticos de biopsias y tener un reconocimiento de esta enfermedad probablemente mejorará el reconocimiento y el diagnóstico de la misma en nuestro país. El siguiente paso es la histología y habitualmente pensamos simplemente en los más de 15 eosinófilos por campo de alto poder, en el que deseamos que nuestro patólogo nos diga exactamente el número, no solamente eosinofilia o incremento de eosinófilos o sin incremento de eosinófilos en el esófago, pero la inflamación eosinofílica es solamente la punta del iceberg de los diferentes procesos fisiopatológicos y de la histología en la esofagitis eosinofílica, ya que la hiperplasia de la zona basal, los abscesos de eosinófilos, la estratificación superficial de los eosinófilos, espacios intercelulares dilatados, alteraciones de la superficie epitelial y la fibrosis de la lámina propia son parte de la enfermedad y por lo tanto el score histológico o el sistema de puntaje histológico en esofagitis eosinofílica ha sido una herramienta multidimensional para poder verdaderamente evaluar diferentes aspectos de la histología y que tiene una mayor correlación con la severidad clínica y endoscópica de la esofagitis eosinofílica. Además de que puede ayudar a tomar decisiones terapéuticas y monitorear a lo largo del tiempo a nuestros pacientes. Ahora, ¿cómo podemos integrar entonces los síntomas, los hallazgos endoscópicos y los hallazgos histológicos y su severidad? Bueno, se ha propuesto en los últimos años un índice de severidad de la esofagitis eosinofílica que integra los síntomas y las complicaciones de la enfermedad, las características inflamatorias y fibroestenóticas, tanto en la histología y en la endoscopía, para poder puntuar al paciente entre enfermedad inactiva, cuando tiene más de un punto, hasta severa, cuando son 15 o más puntos de este score. Está disponible en diferentes calculadoras médicas y si bien está aún pendiente su validación, existen diferentes grupos que están actualmente evaluando su utilidad prospectiva. ¿Qué sabemos del tratamiento en cuanto a alergias, endoscopía y la severidad? Bueno, el tratamiento habitual son las 3 Ds, dieta, drogas o fármacos, como decimos nosotros, y la dilatación. Ahora, se antoja que si el alergeno principal que desencadena el proceso inflamatorio de esofagitis eosinofílica son los alimentos, eliminar los alimentos sería una excelente estrategia para poder remitir la enfermedad. Y sabemos que con la dieta elemental se alcanzan remisiones de más del 90%. Sin embargo, la dieta elemental es costosa y sobre todo desagradable para los pacientes. Entonces, en años anteriores o en el pasado, lo que se utilizaban eran pruebas cutáneas o IgE sérica para poder guiar esto. Sin embargo, sabemos que tienen un muy mal desempeño para poder identificar el alergeno que está desencadenando, además de que son costosas y nos dejan más preguntas que respuestas. Por lo tanto, actualmente no se deben realizar estas pruebas y no se recomiendan para guiar la guía de dieta de eliminación. Lo que debemos hacer entonces es una dieta de eliminación empírica que tienen aproximadamente un 70% de éxito para la remisión y que pueden ser, junto con la mano del nutriólogo, eliminando dirigidamente ciertos grupos de alimentos, principalmente lácteos, trigo y huevo, que son los que principalmente desencadenan esta respuesta con alérgenos, para poder identificar cuál eliminar y llevar a la remisión. La siguiente D son las drogas, en la que los esteroides tópicos a través de un efecto antiinflamatorio local pueden ayudar a la remisión. Los inhibidores de la bomba de protones, que actúan principalmente sobre la disminución de la eotaxina a nivel esofágico y que va más allá solamente del efecto antisecretor ácido, y el dupilumab, que es un anticuerpo monoclonal contra interleucina alfa, la subunidad alfa de interleucina 4, que además disminuye el efecto de la cascada inflamatoria a nivel de interleucina 13 y que es bastante útil en casos refractarios, pero también en pacientes que tienen asma y dermatitis atópica moderada, severa, concomitante, en la que podemos tratar 3 condiciones a la vez con un solo fármaco. Y finalmente la dilatación, en la que se puede realizar a través de buggy o con balón CRE, y cuyo objetivo es llegar a un diámetro esofágico entre 16 y 18 milímetros, o al menos ese diámetro, ya que llegar a ese diámetro tiene una efectividad para tratar la disfagia de más del 95% con un efecto sostenido hasta de 12 meses. Y esos 12 meses es tomando en consideración que estamos tratando a la vez el proceso inflamatorio. Esta maniobra es segura y se ha demostrado en diversos metaanálisis que la tasa de perforación con la dilatación en esofagitis eosinofílica es menor al 0.3%. Y el concepto previo de que necesitábamos disminuir la inflamación para proceder a la dilatación en esofagitis eosinofílica no aplica. Entonces los invito a que en los pacientes que tengan un disminuido calibre lo podemos realizar porque va a ayudar bastante en la sintomatología de los pacientes. Entonces, ya que hemos visto el tratamiento, bueno, ¿con qué vamos a seguir? Seguramente ustedes han leído los estudios y los estudios evalúan a 12 semanas, 24, 52 semanas los tratamientos para esofagitis eosinofílica. ¿Qué hacemos más allá de eso? Bueno, esos tratamientos se pueden sostener. No es que el paciente lo tratamos solamente 8 o 12 semanas con IVP y entonces eliminamos la esofagitis eosinofílica. Estos pacientes requieren una terapia de mantenimiento. Ahora, para tomar esta decisión es importante compartirla con el paciente y debemos tener en cuenta múltiples otros factores como son el estilo de vida, sus preferencias. Hay pacientes altamente motivados para eliminar o hacer dietas de eliminación y otros pacientes que definitivamente no lo desean hacer y que prefieren los fármacos. Entonces, para poder saber qué diferentes estrategias vamos a utilizar, yo los invito a que hagamos uso de la monoterapia al inicio del tratamiento. Porque entonces podremos identificar si el paciente es un paciente que responde a IVP, un paciente que responde a esteroides tópicos o a una dieta de eliminación, y entonces en diferentes etapas de la vida del paciente podrá tomar decisiones de qué terapia usar en ese momento. Son pacientes, casi siempre son pacientes jóvenes y la mujer planea embarazarse, quizá tenga miedo o preocupaciones respecto al uso de fármaco durante el embarazo y prefiere una dieta de eliminación. O al revés, quiere hacer un holiday de la dieta de eliminación que está haciendo porque viene Navidad y entonces sabemos que el paciente responde a IVPs y durante ese periodo podemos utilizar IVPs. Pero estas decisiones tienen que ser compartidas con el paciente. ¿Cuándo hacemos endoscopia de control? Bueno, habrá 3 momentos importantes. El primero es al inicio del tratamiento para identificar su respuesta y así como con cualquier cambio que hagamos de tratamiento, ya sea que cambiamos del fármaco o que modificamos la dosis del fármaco. Generalmente en el caso de los IVP, esteroides tópicos y la dieta se debe hacer la endoscopia de control 8 a 12 semanas para evaluar la respuesta y en el caso de dupilumab entre 12 a 24 semanas. También debemos hacer endoscopia de control ante cualquier cambio de síntomas. Si el paciente nuevamente presenta disfagia, ha tenido obviamente un impacto alimentario, tendrá que realizarse una endoscopia de control. Y existe aún controversia respecto a la necesidad de una endoscopia rutinaria. No hay un consenso claro respecto a la frecuencia óptima para poderlo hacer. Existen algunos datos que los pacientes que se realizan endoscopías más allá de 2 años de intervalo tienen mayor complicaciones, sin embargo eso no significa que estrictamente se tenga que hacer cada 1 o 2 años. Y esta decisión también debe ser individualizada respecto a la gravedad o severidad inicial de los síntomas y de su presentación endoscópica. Para concluir, podemos ver cómo a lo largo del diagnóstico de la esofagitis eosinofílica la severidad, las alergias y la endoscopía juegan un papel importante para poder realizar el diagnóstico, y así como en todo el tratamiento, ¿no? Los invito a que puedan revisar esta revisión que realizamos en conjunto en español para que el público latinoamericano lo pueda utilizar, y también enfocado a los fármacos y diferentes presentaciones de los mismos que tenemos en Latinoamérica y que pueden descargar en este QR. Muchas gracias.
Bueno, muchísimas gracias por la excelente conferencia. Por favor, los conferencistas pueden pasar adelante. Hay micrófonos en el auditorio de ambos lados para las preguntas que requieran hacer, por favor. Doctor Cristian.
Muchas gracias al comité organizador por estas excelentes presentaciones a nivel claramente mundial. Quería hacer dos preguntas bien breves. Una en disfagia que no encuentro causa, que estoy asumiendo una disfagia funcional. ¿Qué rol tiene en la medición de distensibilidad del cuerpo esofágico para estudios de disfagia? Rol de la distensibilidad en endoflip de cuerpo esofágico.
En disfagia funcional.
I would say that is the frontier for the diagnosis of functional dysphagia, because sometimes FLIP brings out obstructive abnormalities that may not have been seen with manometry or even with barium. But I would urge caution, because sometimes when you distend a balloon in a hypersensitive patient, or essentially a functional patient, you may see a reactive contraction of the esophageal body. So in other words, the balloon distension may create a contraction that may look like obstruction. And that reactivity needs to settle down or go away during your study before you can actually take measurements. Because if you treat a reactive esophagus like you would treat a obstructed motor esophagus, you're creating a problem rather than solving a problem. But FLIP may have a role in ruling out a true obstructive disorder in somebody with dysphagia symptoms and all the other tests are negative. Now, if you get to the point where none of these tests are positive, then some of those patients improve with some of the behavioral therapies that we talked about, cognitive behavioral therapy and maybe even neuromodulators.
Sí, solo brevemente para añadir algo, lo que hablaba el doctor Llevó es obviamente encontrar relajación incompleta de la unión esofagogástrica, otros problemas contráctiles. Sin embargo, en algunos casos el endoflip nos puede mostrar un área estenótica muy sutil que se ha perdido en la endoscopía, ¿no? A veces uno mira un área permanentemente cerrada en el esófago medio proximal y ya puede uno regresar y dilatar con buen beneficio, ¿no? No es tan común, pero a veces el flip le demuestra un área fibrótica, estenótica que se perdió en la endoscopía también.
¿Puedo hacer una pregunta breve al doctor Chan?
Sí, señor.
En pacientes, esto es una pregunta clínica. Yo tengo un paciente con baja probabilidad pretest de reflujo con síntomas laringofaringios. ¿Prefiere cápsula Bravo, que tiene un mejor valor predictivo negativo para descartar reflujo, o prefiere una pH impedancio con doble canal para ver efectivamente llegada a faringe?
Yeah, I think this is one area there's not much of a consensus. I think if you look at the most recent San Diego consensus, we basically position both tests as probable options that you can choose. I think one of the things is if you have a low probability, low suspicion for reflux, I tend to do a pH impedance study, especially if they don't have any esophageal symptoms. I think that will actually give me more information, make sure that there's no other, either proximal reflux or non-acid reflux that could be contributing. If they have esophageal symptoms, those are the patients that are more likely to do a wireless pH study, because there's a higher likelihood there will be actual distal, an increase in reflux burden in those patients. So that's one of the ways that I personally would do it. I think if you ask different people, they might give you different answers because there's no clear consensus, but I would think more about the esophageal symptoms and the presence of that.
Muchas gracias.
Siga.
Gracias. No hay duda que el paciente con disfagia, que en una endoscopia no tiene hallazgos relevantes, hay que hacer biopsias para descartar esofagitis eosinofílica, pero otros síntomas y algunas revisiones del doctor Ronifaz lo han mencionado. ¿Cuándo deciden a un paciente con pirosis, que puede ser funcional, o con dolor torácico, hacer biopsias en la endoscopia sin disfagia para descartar eosinofílica?
Yes, so you asked a lot of questions. You covered many areas. So you want me to focus on heartburn? Yes. So if I scope a patient and there's no evidence of erosive esophagitis or any other evidence of objective GERD, would I biopsy the patient? So first of all, I don't biopsy patients with heartburn on a regular basis, just to see if they have gastroesophageal reflux disease. Now, if you look at Lyon, it is used as a supportive evidence, there are studies showing that you have a composed score of histology. I don't think many of us biopsy those patients on a regular basis. The main reason for that is that if you biopsy very close to the esophagogastric junction, you will find in about 20% of normal subject findings that are consistent with GERD. If you biopsy too far enough, you may miss evidence of GERD in patients that truly have gastroesophageal reflux disease. So just biopsying to see if the patient has gastroesophageal reflux disease in a negative endoscopy, I think most of us don't do it. If you ask about functional heartburn, if you suspect that the patient has functional heartburn, they have negative pH testing, they have everything negative, would I biopsy to rule out eosinophilic esophagitis? Although there are studies showing that if you take patients that just have heartburn, about 8% will have eosinophilic esophagitis. But my experience is that usually in patients that do have a component of dysphagia, I would probably biopsy to rule out eosinophilic esophagitis, but otherwise I wouldn't.
Ok, siga, doctor.
Buenos días. Una pregunta, ¿qué pasa con la mucosa gástrica ectópica? ¿Da síntomas, como decimos, laringofaringeo o dolor torácico? No sé, cualquiera lo puede contestar. Gracias.
For patients with laryngopharyngeal symptoms, there have been some studies that have shown that patients with the ectopic mucosa, the gastric inlet patches, tend to have more symptoms or more severe symptoms. So perhaps it could be associated, because some of them could be functioning, secreting acid and other secretions. And there had been some studies that show that ablating those may help, but it's all very small pilot study, case series, is not controlled study. So if you see them, that potentially can be a treatment target, but we need more data to show that it is truly effective to really eradicate all of them in patients with throat symptoms.
Sí, hay también un estudio pequeño, más de 10 pacientes, mostrando que el globo faríngeo puede resolver luego de ablación, pero esto hay que tomarlo con mucha cautela porque a menudo los pacientes desarrollan estenosis luego de la ablación y entonces se vuelve un nuevo problema y hay que dilatarlos. Es que yo lo pensaría con mucho cuidado, ¿no?
In relation to chest pain, I would just like to say there's no really data that these inlet patches are associated with chest pain, but remember some of these inlet patches may have a secreting Pariel cells, so you have to remember that. And that may be associated with even ulceration, but this is very uncommon. The only thing is that it's been suggested by ENT people primarily that it could be associated with global cessation, as was discussed here.
Siguiente pregunta, por favor. Dr. Tak.
In terms of the gastric inlet patch, actually the group who published the case series did a sham control trial that was published in Gastro. First author is Bash Bush, but I think nobody ever followed their guidance, and we are also critical of that. So we are running a sham-controlled ablation study as well for LPR, especially globus, because I think the one paper out there suggests you should do it. I think nobody in the world does it, and I think we need to confirm where we are on that topic.
Yo quisiera preguntarle a Prakash y a Ronnie. Los gastroenterólogos nos enfrentamos a los pacientes con enfermedad por reflujo refractaria como un problema clínico importante, definido por aquellos pacientes que tienen reflujo demostrado objetivamente que no responden a doble dosis de IVP. ¿Cuál es el siguiente paso? ¿Cuándo utilizar otro inhibidor de bomba de protones, por ejemplo rabeprazol? ¿Cuándo escalar a un PCAB? ¿O cuáles son los factores predictivos de las pruebas que nos van a decir cuál paciente va a responder a una funduplicatura? ¿Cuál es el algoritmo en pacientes con enfermedad por reflujo refractaria?
So let me take that first. The algorithm partly depends on what is driving symptoms. What is driving symptoms, right? If they have a disrupted esophagogastric junction barrier, it's easy. Those patients, you're probably going to need to do something beyond medical therapy. If their reflux burden is not very high, we have a relatively simple way of escalating management these days with PCABs. And if you don't have access to PCABs, I think it is worth looking at the potency of the PPIs and going to the more potent ones like rabeprazole or dexlansoprazole and see if there is additional benefit. I will tell you that earlier in 2025, a European group from Bordeaux, Frank Zerbib's group, published a paper showing that even in patients with proven GERD, one of the mechanisms for persisting symptoms is a functional disorder. So it may not be that acid burden is driving or reflux burden is driving their symptoms, but hypervigilance and overlap functional heartburn and reflux hypersensitivity may be driving symptoms. So if that is the clinical impression, so if they have other epiphenomenon of functional disorders, like they have concurrent functional dyspepsia or irritable bowel syndrome or depression or anxiety or hypervigilance, these days we have that questionnaire called EHAS, esophageal hypervigilance and symptom-specific anxiety questionnaire. If they score highly on that questionnaire, then those patients may deserve a trial of neuromodulation or behavioral therapy before you choose to do something more permanent to them.
So I agree. The question that you ask is when should we consider changing to another PPI, which you considered more potent PPI, or switching to a PCAB? And I would say that I would do it when we do optimization of PPI treatment. So when you have a patient fail PPI once a day, before we consider doubling the PPI dose, this is a time to do optimization. There are various things that you can do. One of them is switching to another PPI. So if you're, for example, on pantoprazole and lansoprazole, you can switch to esomeprazole or rabeprazole. Also, because most of the guidelines today do not include PCAB, I see that this is also an opportunity to consider switching to a PCAB and see if it works in these patients. Now, in relation to surgery and So as Prakash mentioned, I would be very careful what drive patients' symptoms after they fail PPI twice a day. And as was already mentioned here, in the majority of these patients, either to be some type of esophageal disorder of gut-brain interaction, and it could be also other disorders that have been mentioned in the literature, like supragastric belching and rumination, although I don't see that common in driving refractory GERD. But you still may have patients that despite PPI twice a day still have an objective evidence of gastroesophageal reflux disease. And a lot of these patients have, for example, a large hiatal hernia. So these patients probably will require surgery to take care of the symptoms.
La última, perdón.
Sí, aquí en este paciente me parece que sí es muy útil la pH impedancia porque te delinea qué camino seguir. El paciente estudiado con medicamentos, si la pH impedancia muestra reflujo ácido anormal, el medicamento no está funcionando, hay que usar otro distinto, mandarlo a cirugía, hacer algo, ¿no? Otros pacientes, la pH impedancia va a demostrar que el reflujo ácido está bien controlado, pero algunos pacientes tienen una alta frecuencia de reflujo no ácido, y si tienen más de 80 episodios de reflujo, sobre todo si tienen regurgitación, sabemos que a esos pacientes les va bien con cirugía. Y por último, si la pH impedancia muestra que no hay reflujo ácido, tampoco hay reflujo no ácido en ellos, entonces sí vale la pena mejor enfocarse en neuromodulación en la vía sensorial.
Bueno, yo, claro que ya el doctor Marcelo me contestó en parte. El doctor Chang mostró en sus diapositivas ventajas y desventajas del monitoreo Bravo y del monitoreo de pH con impedancia, y colocó que una de las ventajas del pH con impedancia es la valoración del reflujo no ácido. ¿Qué relevancia le da usted al reflujo no ácido en los pacientes con síntomas laringofaringios?
Yeah, so there have been some study looking at different components of the refluxate and how it might affect the throat, and there have been studies that have shown that maybe it's not just the acidity, but just having refluxate there can cause enough irritation. One component is the pepsin component. There have been some study looking at the direct effect of pepsin on laryngeal mucosa and how it can cause either inflammation, irritation that can maybe link to symptoms. So that's why one of the thought is that, you know, you just look at acid rather than volume reflux, you might be missing some of these patients where they may have symptoms coming up from coming from these other refluxate component.
I might add to that one of the other advantages of pH impedance is you can look at baseline impedance. And baseline impedance might be a useful metric. And there are some studies, very limited, very small, but there are some studies from Italy showing that if you have a low baseline impedance in the proximal esophagus, in addition to the distal esophagus, those may be your PPI responders that can help heal the mucosal damage that leads to the low impedance.
Bueno, muchísimas gracias a todos por su presencia, gracias a los profesores. Damos por terminada esta sesión.